That's great. So, hi everyone. Delighted to be here today to speak on behalf of General Practice. Just maybe some of the lessons. We only have 10 minutes, so I won't get through everything. But certainly in the last 25 years, as has been mentioned today, GPs have computerized their own practices, and for good reason. So I'll get into my talk. So this is the structure. I'd just like to, some of the reasons, I guess, why we computerized, and also then cover what that allows us to do in terms of the primary use, as been mentioned already, around patient care, and also then some of the, I suppose, developing items that are underway in terms of secondary use and research, and what we're all considering here really is how better we can make those links between patient care and secondary use in future. And I have one example project to discuss that we've been working on quite a lot recently. And then I finally finish on a few key concepts about building in research, and a lot of it has been covered already by other speakers. So why we computerized then? I suppose looking back 25 years ago, it was before I was a GP, but essentially the two main problems in the 90s, I suppose, and early noughties were around paper-based notes on the left and all the inherent issues that lie therein in terms of legibility, accessibility, and other concerns. And also then dealing with the huge volume of paper-based electronic or paper-based results coming back from hospital with very little electronic means to access those. So a few key building blocks that certainly make a huge difference to general practice every day are these. So HealthLink on the right-hand side is a HSE messaging broker in place since 1995. And this is the really silent workhorse who does a huge amount of traffic back and forth between hospital and general practice, and indeed other care settings. And that is, as I said, a foundational stone to what we do every day. And our four GPIT accredited softwares there on the left-hand side address a lot of those paper-based issues that we once had. So what do these basic building blocks afford us? I think they afford us many things, but chiefly among them are, better speed, better safety, and sharing of care, not sharing of records per se, but sharing of care. And it has been mentioned a couple of times already, and I'll go into it again in a sec, just around sharing of information isn't probably where we need to get to. You don't want to be creating silos here, there, and everywhere. You want to be facilitating access. But certainly, as I said, our systems do facilitate us to share care better, even within our own practice teams. And also then standards. And certainly sharing of care and standards of my list of four are the ones that we really have a lot of work to do across the ecosystem. So just in terms of the primary use then for patient care day-to-day in general practice, what do our tools help us to do? I've mentioned some of the key characteristics of the workload, but really it comes down to volume. And I think that's relevant, certainly for the discussions today when we're talking about e-health, informatics, and in a sense, databases, and looking at databases and transactions. So this is a chart of various settings, and indeed the numbers are here as well, in terms of number of visits to Irish healthcare settings last year. And indeed, so 21 million GP visits, probably closer to 30 with GP out of hours and our GP nurse colleagues within practice. So probably pushing on what Dermot had said, around 85, 90% of what's going on in terms of opportunities to update records. And you can see then 3.4 million outpatient visits, 1.5 emergency department visits, 1.1 million day cases, and 700,000 inpatients. So when it comes to updating records, transactions to update databases, certainly general practice is a good place to start. But it also is relevant here, and just with these numbers on the right-hand side, we can see, and this is from Healthy Ireland data, 12% of the population will be likely to pop up in the inpatient database, let's call it. 16% day cases are ED, 36% in outpatients, but 76% of people in our country will attend their GP at least once a year. So you'll find them in the GP EMRs. That rises to over 90% for those over 65. So I guess first key take home is for data our patient capture, GP systems certainly do offer a very strong foundation. Just a note on this as well, and again, I've worked in IT and things in the past, and there is a 30-70 rule that I've heard bandied around in terms of, so 30% of your outlay, your cost, your overall cost for a system over its lifetime is going to be the setup. 70% is going to be your maintenance. And I think that's important to remember, and we do have some early evidence around that. So we just did a study in University of Limerick looking at 10 GP practices across the pandemic, and we examined essentially 500,000 consultations. And to do that, to deliver that care, but also to deliver the follow-up care that general practice visits inevitably generate for us, you're talking double. So if I go back to my chart above, there's probably 50 million opportunities there between seeing the patients, updating the records then, but also going back then to follow up on a given issue or prescription or what have you. So as I said, you're probably pushing 50 million opportunities there to keep records up to date. And I think, as I said, if we're looking at national systems, well, we need to harness those 50 million opportunities. So that's the second point. I guess population and maintenance are key. So primary use, and again, it's been alluded to just in terms of the accessing that great volume of GP transactions in their practices. I think it's not just about grabbing data or creating a copy of data. And I think, as I said, this has been mentioned several times. It's about access. You don't want to create copies. You want all to be accessing the same data. Otherwise, those people over there have that record. Those people over there that record. Maybe the patients have a different record, and nobody's on the same page. So I think we need to be supported, to be actively involved in how we collect and maintain data. And also then as well, just to make the point, if there is indeed the rails set up between general practice and secondary care, which again patients need, we just need to be careful about control of, I suppose, jobs and where they originate and where they finish up. Because again, as I said, general practice is certainly busy. We're not looking for more work at the moment. And indeed, as I said to you, there does need to be clear lines of responsibility. And if we don't do that, as I said, I think there's 50 million wasted opportunities, and we would lose a golden opportunity for our patients to keep things up to date and to keep patients safe. So then, just on secondary use for research and more. So again, I suppose building in data flows, and again has been mentioned, and I really like the concept in the previous speaker, the parallel streams, and I think that is what's needed. You have your patient use, but at the same time you're building in this parallel stream, which can safely give us anonymized patient data or what have you for audit, research, service evaluation, quality improvement processes. Our own GP programs, in terms of the learnings there, they've got basic reporting functionality, but they weren't set up with this in mind. So I suppose we've learned the hard way about how difficult I suppose it is to do this after the fact. So that's, I think, why it's great to have the opportunity to speak here and indeed to, I suppose, implore us all to be thinking of this right now before we embark on this journey. But things are improving, and again, just the example project, we're involved within that from the Irish College of GPs. So the Sentinel project has been going for years and years, and it's essentially where GPs who are seeing influenza-like illness are coding it in the community. So that's all it is, but it's about how you get that information from those communities where flus and other diseases are bubbling up. And we've automated that process with the help from our vendor partners in the last year or so. So now, essentially, the GPs are just doing their job as always, but it's collecting that data and sending it back to the HSE and the HPSC to, I suppose, sound the warning, sound the alarm bell, where these infectious diseases are going to put pressure on hospital, local hospitals. It's involved collaboration, certainly, and as I said, our vendor partners have been very helpful in this, the GPIT group and the HSE. Of course, when there's patient data, we need data protection activity around it and governance in that regard, and also resourcing. But it is an example of what can be done from just a little corner of the GP EMR, and we're very interested to expand on that. So can we build in research to improve patient care, guide public health policy and drive innovation? I certainly think we can, and people, I hope, across the healthcare system, both in care delivery and research, will be afforded the same speed, safety, sharing of care and standards that we get in general practice every day. And these key concepts, I think, are important to that. To build it once, to use twice, this parallel model that was spoken about in terms of data access, that we don't have loads of silos, we're just accessing the same information and all keeping it up to date on behalf of patients. Interoperability, consent, anonymization and governance. And the last 2 points are obviously in terms of establishing trust and keeping patients on board, which is huge. So, and again, learning from general practice and being inclined to build it in from the start if we can. So those are my 3 key points. Thanks very much. Look forward to the discussion.